The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. I'm John Welliver with the Illinois Chapter, American Academy of Pediatrics. I thank you for joining us for today's webinar on the business side of vaccines, billing, and coding best practices. This webinar is sponsored by the Illinois and Chicago Department of Public Health. Today we are joined by Becky Dolan from the American Academy of Pediatrics. In accordance with requirements of the FDA, the audience is advised that the information presented in this continuing medical education activity may contain references to unlabeled or unapproved uses of drugs or devices. Please refer to the FDA-approved package insert for each drug and device for full prescribing and utilization information. The course directors, planners, faculty, and reviewers of this activity have no relevant financial relationships to disclose. Evaluations will be sent post-webinar by Rush University with a link to the survey to be completed. Once the survey is completed, you will receive your certificate via email from Rush within 2 weeks of completion. If you're going to watch the webinar in a group instead of your own individual link and/or computer, we will need the group's information before or immediately after the webinar in order to add you to the registration list we send to Rush University, and you will need to complete the evaluation post-webinar. Please send an email if you haven't already to jwelliver@illinoisaap.com, and that's JWELLI, V as in Victor, ER, @illinoisaap.com. On the last slide of the presentation, I'll have my contact info up there, so don't worry if you don't have a pen or a pencil handy. And then you'll have to provide names, credentials, and a valid email if you're not logged into a webinar from your own personal link and/or computer. Otherwise, the CME, CNE credits will not be awarded. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel on the right side of your screen, and Ms. Dolan will answer them at the end of the presentation. After this webinar, you will receive an email with a link to the recording of today's webinar as well as a PDF of the PowerPoint slides. Now I would like to introduce Becky Dolan. Ms. Dolan holds a master's degree in public health education from Tulane University. She has spent the past 8 years at the American Academy of Pediatrics working in the Department of Practice on Coding, Private Payer, and Medicaid issues. She is a certified professional coder and a certified pediatric coder through the American Academy of Professional Coders. Previous to starting her work with the AAP, she spent over 10 years working in a private pediatric office where she worked in the front office, coding and billing, and also a part of the clinical staff. Please join me in welcoming Becky Dolan.
Thank you, John. Good afternoon, everybody, and welcome to this coding webinar. Again, as John said, there are no financial disclosures, and I will not be speaking about any unapproved FDA devices or medications, I promise. Just some of our objectives, be able to differentiate when and how to use the 6 vaccine administration codes, how private payers and Medicaid will differ here in Illinois, be able to properly code for vaccine products, understand how to handle administering of new vaccine products to ensure payment from payers or families, learn how to code for vaccine-only encounters, and how private payers and, again, Medicaid do differ here in Illinois. I will try to make this as painless as possible, especially on a Friday where it looks like the sun might be peeking out here, which we haven't seen in a while. So why do we care? Why do we care about accurate coding, especially accurate vaccine coding? Well, it allows possibility for increased and appropriate payment. We want to get paid for what we're doing. Decreases provider and practice liability. It improves information flow, especially when it comes to quality metrics. Payers are now looking at your vaccine rates, so it's very important that we input the correct data when we're sending this off to our payers. Given that we're going to have the biggest change I think any of us have seen in coding since we all began with ICD this year, I'm going to start talking about the ICD side of vaccines. In ICD-9, how do we report? Well, under ICD-9 guidelines, we really should only be reporting the V20.2 when a patient is present for their well child or well baby exam. Remember, the V03 through V05 codes were developed to link to the specific vaccines and administration when given outside of the routine well baby or well child exam or when we see adults. However, some payers still require the VO3 through VO5 during routine well baby or well child exams, which does go against ICD guidelines. And unlike CPT, ICD-9 guidelines are under HIPAA. Now let's take a look at what's coming up. Vaccines and ICD-10. We are scheduled and on track to implement ICD-10 on October 1, 2015. When we do, there will only be a single code for vaccine administration. Now this is only on the ICD side. Please do not get confused. This does not impact CPT. This is strictly an ICD thing. We will report Z23 for all vaccines. Doesn't matter if it's a DTaP, MMR, IPV, we don't care. It's Z23 for all vaccines, regardless of when they are given. So we will still use the Z23 during a routine well child exam, or when the patient presents for an acute issue where they receive vaccines. Again, this impacts only ICD. Your CPT reporting is not impacted by this. So what happens when vaccines are not carried out? We have ways to report that in 9, and we kind of have a way to report it in 10. Both ICD-9 and ICD-10 do contain specific codes to tell payers why a vaccine was not given. You do report these as a secondary diagnosis only. If you look at the chart here, there is a direct one-to-one crosswalk for all I-9 vaccines not carried out to I-10. So if it's an acute illness, we would report V6401 in ICD-9 up until September 30th. Starting on October 1, it would be Z28.01. So let's take a look at a vignette here. A father brings in his 12-month-old daughter for her preventive medicine visit, where she's due for her MMR and her varicella. The physician discovers that the patient has already had chickenpox and therefore will only give the MMR. So in I-9, we would report the 99392 and link it to the V20.2, the VO5.4, because they need the varicella and we're telling the payer they need it, but then by adding in the V64.08, we're telling them they couldn't get it because they already had the disease. And then, of course, you would link your MMR and the administration codes to your V20.2. Now let's look at that in ICD-10. Same situation. Patient comes in for her MMR and varicella. Physician discovers patient's already had it, so they only give the MMR. So our CPT side's not impacted. We still use our 99392, and now we're going to link it to Z00.129, because that's for a routine infant child check without abnormal findings. We list our Z23 and counter for immunization, and now we're going to have Z28.81. Vaccines not carried out because patient already had disease. Now the issue here is that we're not able to tell the payer what they couldn't get because we don't have specific ICD codes for the specific the specific vaccine they couldn't get. That's one piece of information that's going to be missing, and right now we're not going to change that. It's just going to be the way we have to report it for now. So let's continue to look a little bit at the ICD-10 coding. So we have a 6-year-old who presents to their pediatrician for atopic dermatitis. During the encounter, the physician determines they need their influenza vaccine. So the physician decides to counsel, and it's given. So in this case, we're going to put our L20.89 for other atopic dermatitis and Z23. Again, we don't have a specific code for influenza, so we list Z23. Another one here, a 6-month-old presents for their well child check. The baby is healthy and vaccines are ordered. In this case, we don't care what vaccines because for ICD purposes, we don't need to know that. So in this case, we'll do our Z00.129 and the Z23. So again, this differs from I-9 in that we will add that Z23 in addition to the well child code. In this case, it's the Z00.129, and then we add on the Z23. Next, we're going to take a look at CPT. I can't stress this enough. We are not changing anything on the CPT side when ICD-10 comes into place. I get asked that a lot. It has nothing to do with it. So ICD will change, CPT, HCPCS, none of that will change. So what is CPT? It's a listing of descriptive terms and identifying codes for reporting medical services and procedures. It is a registered trademark of the American Medical Association. Remember that for each vaccine administered, you do report one CPT code for the vaccine product and at least one CPT code for the administration. Again, this might differ a little bit from Medicaid here in Illinois. So let's look at our pediatric immunization administration. These codes have been around a few years now. Most people are fairly comfortable with them. However, I still get questions from time to time about the proper use of these codes. The 90460 is an immunization administration through 18 years of age, any route of administration, with counseling by a physician or other qualified healthcare professional. This code represents the first or only component of the vaccine or toxoid administered. 90461 is an add-on code to 90460, and you use that for our multiple component vaccines. So it's used for each additional component beyond the first in a single vaccine. There's still a lot of confusion as to what a qualified healthcare professional is. A physician or a qualified healthcare professional is an individual who, by education, training, licensure, regulation, and facility privileging, who performs a professional service within their scope of practice and can independently report that professional service. That's the key right there. Independently report a professional service. Are they credentialed with the payers? Can they be credentialed with the payers? And these are distinct from clinical staff. Clinical staff, a person who's a clinical staff works under the supervision of a physician or other qualified professional and who is allowed by law, regulation, and facility policy to perform or assist in the performance of a specified professional service. These are people who cannot be credentialed. Your nurses, a lot of times lactation specialists, they are not able to be credentialed, so they're considered clinical staff and do not meet the criteria for qualified healthcare professional. These were defined by CPT, not the Academy, not by anybody else. This was a CPT designation. The other question we get a lot is, what defines a component? Well, a component refers to each antigen in a vaccine that prevents disease caused by one organism. Conjugates or adjuvants contained in vaccines are not components, and they are considered part of the vaccine. Multivalent antigens or multiple serotypes of antigens against a single organism are considered a single component of vaccines. That says a lot, but what does it mean exactly? Well, it means that our HPV is a single component. Our pneumococcal, the Prevnar 13, that's not 13 components. That's one component. However, our TD, that's two components, because against the tetanus and diphtheria. Our pentacell, that's 5. You got the diphtheria, tetanus, pertussis, Hib, and IPV. So this just breaks down how many components we see in our most commonly administered vaccines and how you would report the immunization administration codes if you were able to bill based on components, meaning the criteria were met. Patient is 18 years or younger, and there was physician or qualified healthcare professional counseling. What happens if the criteria are not met for reporting the 6061, meaning a patient is 19 years or older, or the physician or qualified healthcare professional does not counsel? Let's say an RN within her scope of practice goes in and counsels on the vaccine. Well, then we are stuck with our non-age specific immunization administration codes, and we've got 4 of those. Those have not changed. They have been around a very long time. They are different from our 6061 in that they are reported based on vaccine, not components, and they are split apart based on route of administration. So the 90471 and 72 are both for injections. The 90471 is when you give a vaccine either via subcutaneous, intradermal, intramuscular, and then if you give an additional injection, you would report 90472 in addition to 90471. 90473, 74 are our oral or intranasal codes. 90473 is for our first or only oral or intranasal. The 90474 is each additional. Now remember, 90472 and 74 are both add-on codes. You report 90472 in addition to either the 71 or 73. You report add-on code 90474 in addition to 90471 or 90473. You never report 90471 with 90473. You cannot do that. So again, how do these differ? Our pediatric codes versus our non-pediatric codes. And by that I mean there's an age restriction. We still can use the 90471 through 74 in pediatrics. Well, the 60 requires the counseling by a physician or qualified professional. The 6061 is reported per component. And again, 6061 has a specific age requirement. It has to be 18 years or younger. Versus the 9047174, which is reported based on route of administration, whether it's injection or it's oral or intranasal, and it's reported per vaccine. We don't care how many components are within that vaccine. Another issue that gets brought up from time to time is what is required as part of the counseling in 9046061. So in this case, the physician or qualified professional must document that all vaccine components were counseled on. Documentation should reflect what was done as with any procedure, and this includes the guardian or parent receipt of the vaccine information sheet. But that's not enough. You do need to have more than that. Risks and benefits of vaccine components are discussed. Any issues or concerns that have to be addressed by the parent need to be documented. The care plan that you suggest to the parents over the next few days to deal with possible side effects of each component, and when to call the office. Now this is just guidance. There are no official guidelines out there on this. We've had payers who question the amount of documentation, but if you can at least show that counseling was done per component, you'll be fine. These are just suggestions so that payers will understand what you've done for that encounter. Now, if your physician or qualified professional does not counsel on all vaccines given, then you cannot report the 6061 for all of them on that date of service. You will only report the 6061 for those that were counseled on and documented. It has to be documented. For those vaccines not counseled, you defer to the 71 through 74. There is a CPT guideline that states to report your add-on code 90472 for any additional injections or 90474 for any additional oral or intranasal in addition to 90460. So that means you cannot report 90460 with 90471 or 90473. Let's look at a quick example. Your physician counsels a mom on the MMR, but does not counsel on the annual influenza, which happens to be an intranasal. So you would report 90460 and 61 with 2 units for your MMR. Remember, it's a 3-component vaccine. However, you would report 90474 for the additional vaccine given, which happens to be an intranasal vaccine for the influenza. So you cannot report the 90460 because you did not have documented counseling on the influenza. Next, we're going to take a look at the vaccine products themselves. Now, these are found in the medicine section of CPT manual. They run from codes 90476 through 90749. These identify the specific vaccine product only. You do use these in addition to the administration codes. So codes for common vaccines include 90700 for our DTaP, 90713 for our IPV, 90716 for varicella, and 90744 for Hep B. So these are reported in addition to the administration, unless of course you're billing Illinois Medicaid, which is a little different. So vaccine product codes are a little different from any other CPT Category 1 code in that they are released twice per year. All CPT codes are released in January, but because of the growing rate of vaccines coming out mid-year, they added on a July release date to accommodate all the new vaccines. So codes posted on January 1st to the AMA site become effective the following July 1st. Codes posted on July 1st become effective the following January 1st. Vaccine product codes are often released before the vaccine is even on the market. You have to be very careful about that. And remember, anytime you see a lightning bolt next to any code, it indicates the vaccine is still pending FDA approval. And that means it will not be covered basically by any payer. So we will not be reporting that because the vaccine may not even be on the market yet. On the bottom of this page is the site for the AMA updates. You should bookmark this, keep it so you can check it out. Usually by the end of June they have release dates, the released information for July 1st. So keep this somewhere handy so you can keep an eye on what's happening with the vaccine product codes. Now, as I said, without FDA approval, a vaccine will most likely not be covered by a payer. But in addition to that, most payers also follow the Center for Disease Control's Advisory Committee for Immunization Practices, also known as ACIP, or AAP, AAFP routine recommendations. Therefore, without the FDA approval and routine recommendations, most payers are not going to cover. So for more information, I do have some websites up here. You always want to keep a look out for CDC ACIP recommendations, which are usually published in the MMWR, and the AAP recommendations, which are published in our Red Book online. Sorry, we're having a moment difficulty here. There we go. Sorry about that. So when looking at our products, we want to make sure that we are reporting the most accurate CPT code that identifies the product you are administering. We want to look at the product. Is it a combination product? Is it a single component product? What disease are we targeting? For example, is hepatitis B. Is there a distinct dosing schedule? Some vaccines are produced by different manufacturers with different dosing schedules. Some are a 2-dose, some are 3-dose. Some have different chemical formulations. There's a polysaccharide versus a conjugate. And also look at the route of administration recommended for that vaccine. Is it a subcutaneous or intramuscular? Many vaccine products are very specific to a single product on the market. So always be very, very cautious of what you're reporting when you're submitting to your payer. Remember, if you're administering a vaccine product that contains a combination of vaccines, for example, your MMR, you must report the appropriate combination code. You would not report each individual product code. We've had a lot of changes this past year in the vaccine products. So we're just going to take a look at some of those right now. Always keep in mind the CPT symbols for updates. Remember, the lightning bolt means FDA approval is pending for a vaccine product. A dot indicates we have a new code. The triangle means we have a revised code, something's changed. And the hashtag sign is really a resequenced code, so it doesn't really mean much to the code itself, just that the code had been moved from another area to kind of fall in line. If we had an MMR, or excuse me, a meningococcal that was in a different section from all the other meningococcals, they may have moved it and indicated that it's resequenced. So updates for 2015. Many codes were revised and indicated with a triangle in the vaccine products section simply to align with official CDC language. However, the underlying use of the code has not changed. So effective July 1st, 2015, many codes have been changed. They will be published in CPT 2016. But as you can see from below, all they're doing is adding in appropriate abbreviations, things like that. So the codes themselves, the product themselves have not changed. They're just aligning with CDC language. So these are just examples, 4 of them out of probably 20 that have been changed. I just wanted to give you an idea of what they were doing and to not worry that the codes, the product themselves have not changed. They're just adding in language to help define and align with CDC. Now what is changing, we've had some new codes this year. We have one for cholera. Not sure you'll use that very often, but it is a new code, 90625. It was implemented January 1 of this year. CPT 2016 is when it will be published. Probably 2 you are familiar with are the new meningococcal vaccines, the Bexsero, which is reported with the 90620. That was implemented kind of a little off here. On February 1st it was implemented from the CPT panel meeting. That's a little different than we're used to seeing. Same with the 90621, they were for the Trumemba. They were both implemented February 1st and will appear in CPT 2016. They are both FDA approved, which is why they do not have a lightning bolt. Next new code we're going to see, which is still pending FDA approval, is a new combination vaccine. There's a lot here. It's the DTaP, IPV, Hib, Hep B. Again, implemented January 1st as a new code. You'll see it in CPT 2016, but again, it is not FDA approved yet. So both codes, 90630 and 90651, which are below, were published in CPT 2015 with the FDA pending symbol. However, both have since been approved and will appear in CPT 2016 with no lightning bolt. This is where having the updates done twice a year does help, because they did receive FDA approval after the 2015 book was released. So if you went online, you would have noticed that the lightning bolt was removed from the 90630, which is a influenza quadrivalent for intradermal use, as well as the HPV-9, which many of you are probably starting to use in your own practice. Because again, the FDA approval was given in December of 2014, which is long after the 2015 CPT book was released. They're starting to remove vaccine products. Obsolete products that they no longer make. They're probably hoping to make room as new products are going to come out. So you will no longer see a code for the pneumococcal conjugate 7-valent. That's being removed. The tetanus toxoid being removed. And the individual measles, mumps, and rubella vaccines are being removed, as well as the measles and rubella. They're starting to clean up the product area and removing codes for products that just no longer are made. Let's take a look at the influenza products for 2014-2015. Again, for the I didn't update that line, I apologize. 2015-2016, influenza season, many vaccines will again be in the quadrivalent and trivalent. We had this last year and there was some confusion, and we're going to have it again. They're still going to keep making the trivalent for most of the products. You are to be sure to report the appropriate code for the vaccine given. Make sure you're using your quadrivalent if that's what you're given. Make sure you use the trivalent if those are what you're giving. FluMist trivalent is again not being manufactured, so we are only going to have the FluMist quadrivalent on the market this year again. This is just an outline of all the codes that we know so far with their products. Some new ones may come on the market between now and then, but we are not anticipating any. So you can have this for your reference. Let's talk about coverage for vaccine products. I think we kind of mentioned this before, but I can't emphasize it enough. We've had some issues, especially with the new HPV-9. This has come about. So remember, without FDA approval and the CDC's ACIP routine recommendations, a vaccine may not be covered. That typically will fall in line with the publication date of the recommendations. So the FDA can approve a vaccine, but until the recommendations are published in the MMWR, which stands for Morbidity and Mortality Weekly Review, the vaccine will most likely not be covered. Now, AAP recommendations usually follow ACIP recommendations, but can vary. They're usually the same. We've had some instances where they're different, but not by much. Never simply follow manufacturer's recommendations. A manufacturer may say it's safe for a 9-year-old to get a vaccine, but if the ACIP recommendations say that routine vaccination begins at age 11, that is when most payers will cover. If you and the parents decide to give it at age 9, they have to be aware it may not be covered by the payer. So I'm not talking about manufacturer's recommendations. We are talking specifically about payer coverage. And payer coverage will most likely, 99% of the time, follow ACIP recommendations. So it's very important that the physicians and the nursing staff understand and know when the Mortality and Morbidity Weekly Review came out publishing the recommendations, what date that came out, as well as what the recommendations state. There can be some lag time between FDA approval and the recommendations being released. Sometimes it's a couple of months. So again, don't let anybody convince you can start giving vaccines because the FDA has approved it. You need the ACIP recommendations to be released. Now, even with ACIP recommendations being released, we have some payers that'll lag behind. We're still waiting on Humana. I think they just released their approval for the HPV-9 just recently, even though the MMWR came out, I believe, in March. So there still can be some downtime, but until that point, make sure you are not giving a vaccine without the family knowing it may not be covered if the ACIP recommendations have not been released. Always check with your payers, though, prior to giving any new vaccine. So once we find out a vaccine is covered, what kind of payment should you expect for that product itself? Well, the payment should include the actual product, what you paid for that product. Above that, it should contain personnel costs for the ordering and inventory. Storage costs. You have to store these vaccines, and I know there's more stringent rules out now, especially from Illinois Medicaid just released more stringent rules. They're coming out with specific vaccine storage and handling protocols. You are absorbing that cost as a practice. Insurance against the loss of a vaccine in case there's a catastrophic event or you lose power and the backup generator goes. Something could cause you to lose part of your supply. Recovery of cost attributable to that inventory shrinkage, wastage, and non-payment. You have to be able to cover some of that. Let's say you pull up a vaccine and the child decides he or she doesn't want it. And mom says, that's fine, we're not going to get it today. Well, now you've just wasted a vaccine if you couldn't give it that day to somebody else. And lost opportunity costs. You're required to maintain this large inventory, and that's money wasted. Payment should be free of any discounts and based on a transparent and verifiable data source. A great resource for practices is the CDC vaccine price list for the private sector. Make sure you're looking at the private sector cost. The link is right there. Again, keep this on a bookmark. This is where payments should begin. It should really go up from here, but this is a good way for you to understand even how much you're paying for the vaccine. Shouldn't be any more than what's on this list here. The payment should cover the vaccine product purchase price, as well as all the related office expenses that we talked about in the last slide, and a return on investment for the dollars that you invested in your inventory. This is an investment you're making in your practice. And again, here, this is at least 125% of the current CDC vaccine price list. So that's the recommendation of the Academy. If you find that your vaccine product rates are below this, be sure to read over your contracts with each payer. Make sure they are paying what was negotiated in your contract. If they are, use this information when it's time to renegotiate your contract to get better pricing, more fair pricing. Remind the payer that these are indirect costs that are not taken into account with the vaccine administration codes. They have their own work built into them. This is separate from that. Excuse me. So we're going to quickly look at administration done with an E&M service. So if a significant and separately identifiable E&M service is performed, you will report the appropriate service E&M service code in addition to the product and administration codes. Modifier 25 will be required when reporting a problem-oriented E&M service in addition to administration. Modifier 25 should not be required when reporting it with a preventive medicine service. However, NCCI edits have required this now, so most payers have followed this. So well child check, append modifier 25 if you're given vaccines. You have to remember what modifier 25 stands for. It's a significant and separately identifiable E&M service by the same physician on the same day as a procedure or other service. So that has to be a service above and beyond the procedure you're also reporting, which in this case is the vaccine administration. Should be medically indicated and necessary. So what happens with a vaccine-only encounter? Patient presents for the sole purpose of vaccines. Very common during flu season, and common when a patient needs a subsequent dose, such as a second or third HPV. If the vaccine is the only thing that is being addressed, nothing else is brought up, code only for the vaccine administration and product. Do not report a separate E&M service for vaccine-only visits unless the service meets the criteria for using modifier 25. Question comes up, what about 99211? Well, 99211 is the lowest level E&M service. It's what we call our nurse-only visit because a physician typically will report a higher level service, and the 99211 does not require a physician to be face-to-face with the patient for the physician to bill out under a nurse, for a nurse to perform the service and the physician to bill it out, When a patient sees the nurse only for vaccines, when should 99211 be reported in addition to the product and administration? But we have to think about what's included in vaccine administration. And what's included is administrative staff services such as making the appointment, preparing the chart, billing the service, and filing the chart. Clinical staff services include greeting the patient, routine vital signs, obtaining a vaccine history, any past reactions, indications, giving a vaccine information sheet, and answering routine vaccine questions, preparing the vaccine, administering it, and observing for any immediate reactions. So there's a lot that's contained in the immunization administration codes. So what additional services would be required to report a 211? Well, again, the service must be medically necessary. There must be a separate and significant issue addressed from the administration. The nurse evaluates, manages, and documents the significant and separate complaint or problem unrelated to the administration. What do you need to document? Date of service and reason for the visit. Brief history of significant problems. any exam elements, such as vital signs or appearance of a rash, brief assessment and or plan along with counseling or patient education done, signature of the nurse and supervising physician, and again, all of this has to be unrelated to the vaccine administration if you plan to report a 211 on the same day as administration. Illinois Medicaid does take exception to this. Private payers do not. Under Illinois Medicaid, you can report a 99211 on the same day as a vaccine-only encounter. They have this in their handbook, so for Illinois Medicaid, it is allowed. Private payers, it is not unless it meets the criteria for the use of modifier 25. And again, they're both significant and separately identifiable. Just going to mention modifier 33 very briefly. This is a modifier that's been around for a couple years now since the ACA came out. Not many payers use it. Most payers have their policies in place without it. Some do require modifier 33. It's used for any service that is done as part of a preventive medicine encounter that's under the Bright Futures or the USPSTF Task Force A or B rating. It's also used for vaccines that are given as part of ACIP routine recommendations. So you may find some payers do require modifier 33 on those vaccines. For vaccines that are given that are not part of ACIP recommendations, you would not use modifier 33. Now, modifier 33 can be appended to both the administration codes and the products, but again, only for ACIP routinely recommended vaccines. There's a link at the bottom for more information on modifier 33, but by now, most of you probably know which payers want it and which don't. Just real briefly want to talk about when not to report IA codes, which may sound odd, but we get these questions in a lot. You do not report your vaccine administration codes when immune globulins are given. For example, the RSV, which is Synagis, that's an immune globulin. It's not a vaccine. So in that case, you would report your product code with the administration code 96372. So again, immune globulins are not vaccines, so we do not report vaccine administration codes with them. The next one we get asked about a lot is the PPD placement. Again, it is not a vaccine, so we would not use our administration codes. Plus, 86580 does take into account the placement. So you would only report 86580 for the PPD administration and for the actual serum that you're injecting. Just want to look at Illinois Medicaid, Vaccines for Children, and the Affordable Care Act. The increased payment that we all saw over the past few years has gone away. That did stop in December of 2014. VFC still does not allow the reporting of components. So for you in Illinois, it doesn't really matter. You don't bill administration codes to Illinois Medicaid. However, if that did change and we could bill based on components, we would have to convince the state otherwise. We do continue to advocate for the recognition of 90461 to the VFC, but it would require a statute change in the legislation, so that is why it hasn't been as easy as we had hoped. NCCI edits. The Affordable Care Act requires state Medicaid programs to implement this. This is something we've never dealt with in the past, but in 2013, remember a new edit came out bundling all immunization administration codes and all E&M services. So without modifier 25 on our E&M services, when also billing the administration codes, our service was being denied. And remember, if you're billing a well sick on the same day, be sure to append modifier 25 to both the well and the sick if you're giving vaccines. However, again, since Illinois Medicaid does not pay on IA codes, this was not an issue for Medicaid, but many private payers have begun to follow, especially now. Just want to mention modifier SL. It's reported when a vaccine is a state-supplied vaccine. It appears that Illinois Medicaid does require this for the HPV vaccine if the provider is not enrolled under VFC. So if you're not a VFC provider, let's say you're an OBGYN, but you give an HPV vaccine to a patient who belongs to VFC, you can be paid for the cost of the vaccine and use modifier SL. Don't want to spend a whole lot of time on National Drug Code. A lot of the information is here. A lot of the government agencies are requiring the use of National Drug Code, especially Medicare, Medicaid, TRICARE, CHAMPUS, the governments, and some private payers. It's used for all drugs, including vaccines. Most are 10 digits from the FDA. However, the HIPAA standard, which is how we bill, requires 11 digits. So over these next few slides, you can get a sense for how to change a 10-digit NDC code to an 11-digit NDC, what makes up the segments. I'm not going to go through all this. You'll have it on your slides. Again, HIPAA compliant NDC numbers are 11 digits, not 10. So we cannot bill, most payers don't allow us to bill the 10-digit NDC. So you would add appropriate digits as however the NDC is laid out. If it's a 4, 4, and 2 NDC, you'd add a 0 to the beginning. If it's a 5, 3, and 2, you'd add the 0 to the second segment in the beginning. Let's briefly go over some vignettes now. When we talk about coding, we'd like to talk about vignettes and how coding is part of the real world. We're going to talk first about our private payers because, again, it will differ for Illinois Medicaid. A patient or parent is counseled by a physician or qualified healthcare professional on 2 single component vaccines. The physician or qualified professional gives the vaccines. Patient is 18 years or younger. What codes do we use? We'd use our 90460 times 2. There was appropriate counseling and 2 single component vaccines. So we'd use a 60 with 2 units. Patient or parent is counseled by a physician or qualified professional on 2 single component vaccines. The nurse gives the vaccines. Patient is 18 years or younger. Again, it would be the 90460 times 2 because it doesn't matter who administers as long as the physician or qualified healthcare professional counsels. Next example, the patient or parent is counseled by a physician or qualified healthcare professional on 1 single component vaccine. The vaccine is given. Patient is 19 years old. In this case, we'd either report our 90471 or 73. If it's an injection, we'd use our 71. If it's the intranasal, it'd be a 73. This is because the patient is 19 years old. We no longer qualify for the pediatric vaccine codes. The patient or parent is counseled by a physician on multiple component vaccine, Physician or qualified healthcare professional gives the vaccine. Patient is 19 years old. 90471. Again, the patient is 19 years old, so we cannot use the 9046061. 71 through 74 does not take into account components, so it would simply be a 90471, even though there's multiple components. So patient or parent are not counseled on 2 multiple component vaccines. Both are injectables. Patient is 5 years old. We'd have to report our 90471 and 72 because even though the patient meets the age requirement, counseling is not done. Next example is the patient or parent are counseled by the nurse on 2 multiple component vaccines. Both are injectable. Patient is 5. Same here, 90471 and 90472, because again, even though the age requirement is met, vaccine counseling done by the clinical staff does not meet physician or qualified healthcare professional counseling requirements. So we're stuck with our 71 and 72. Patient and parent are counseled on 2 vaccines as part of a well child check. Because the patient is sick, the physician has them return in 2 weeks for shots only. When they return, the patient only sees a nurse. What codes are reported for the counseling during the well-child check? Unfortunately, there's nothing we can report. The way the codes were written, we do not get credit for that. So what codes are reported for the administration? It has to be the 7-1 through 7-4. Because this is a nurse-only encounter and the counseling didn't take place on the same day by the physician, we have to use the 7-1 through 7-4 for the administration. Next one, the patient or parent is counseled on 3-component vaccine. Given that same day are 2 single-component vaccines where no counseling is documented. Patient is 12 years old. So in this case, we would report our 90460 and 90461 times 2. That's for our 3-component vaccine that was counseled on. And then you report 90472 with 2 units for each additional vaccine that was given that day where no counseling was done. We can't report our 60 and 61 for the vaccines that are not counseled on. We're just going to look real quickly at a couple Illinois Medicaid vaccine examples. An established patient presents for her 13-year-old well check. She has never received her HPV. The physician counsels the mom and patient on the Gardasil vaccine and asks the nurse to administer. What is reported for the entire encounter? We would report our 99394 for the well check and the 90649 with the SL modifier. And this is only if you're billing the actual product out. Otherwise, you would just report the 90649. And that's the product code for the Gardasil, which is submitted for payment for the administration. Same patient returns 6 weeks later for the second Gardasil. She sees a nurse only or a physician for the injection. In this case, 99211 can be reported because it's Illinois Medicaid, and the 90649 you would use as the product code. We don't bill administration codes to Illinois Medicaid. Just going to wrap it up here. Some resources. We have some links to the NDC codes in case you need more information on that. For more information on billing Illinois Medicaid for vaccines, you would visit that website there and refer to section A-226. That'll give you more information on that, on vaccine coding to Illinois Medicaid. Some AAP resources which we will share after the conclusion of today's webinar. We have a vaccine coding table which helps determine which code goes with which vaccine product. We have an FAQ on the IA codes. We also have a position paper on reporting the 99211 with the IA codes. And that is it for me. Thank you.
Thank you, everyone. We will now begin the question and answer session. So if you have any questions, please type them in the questions box to the right side of your screen, and then we can get those answered for you. The first question is, will handouts be available? I will be sending out the presentation as well as the PDF of the slides for today's presentation. So yes, I will get those out to you either this afternoon or Monday morning.
The next question is, for patients that have regular insurance, do we charge the admin fee of $23.87 for Illinois, or do we charge the regular fee? No, that only refers to Medicaid. For all private payers, you would report your appropriate administration fees, however you have those set up. And remember, you report the administration codes, and you can report the fees for both the 90460, 61, and 7-1 through 7-4. So no, you are not limited. That's only for those people who qualify for VFC. Next question. The physician must say in dictation that they counseled on immunizations. What's all that must be included in his dictation? Well, again, we kind of outlined a little bit what has to be documented, and I guess you can interchange the word document for dictate. That they counseled the mom or dad or other caregiver on all the components. So they really, in a dictation, they probably can list them out. on the DTP, the Hib, and hepatitis B, and what exactly they talked about. So it's the same thing as how you would document. So at minimal, they should at least say that they talked to mom and dad, other caregiver, about all the components, list them out, and that again, were any concerns addressed by mom? Did mom have questions? And then they should always be telling them what side effects to look for, when to call the office. And again, that might differ based on if the child had a tetanus vaccine or not. So it really should depend on what vaccines are given, what the physician talked about with the parent, and any questions the parents had. Again, these are strictly just guidance. It's not official guidelines. There's no documentation guidelines here, but just kind of what we suggest in order to meet a payers who might have a little more rigorous standards for that code. Okay, next question. To clarify, do you bill to Medicaid differently when a patient comes in just for immunizations if a provider educates them versus just seeing the nurse for injection? No, it wouldn't matter for Illinois Medicaid because Illinois Medicaid does not recognize the administration codes. So for Illinois Medicaid, what you would do is you would report the product code simply if the patient walks in and sees someone, obviously within their state scope of practice, whether a nurse or a physician, and the vaccines are given. Because we don't distinguish between the vaccine counseled and not counseled for Illinois Medicaid, it really does not matter in that respect. Just so long as the vaccine information sheet is given, the vaccines are given to the patient, doesn't matter as long as the person administering is operating under their state scope of practice. And then last one's a technical one.
The next question is, will the questions asked be available on handouts as well or on a web page? You can definitely listen to the questions asked at the end of this webinar because the recorded webinar will be posted on a page, and I will definitely send everyone who participated the link to that.
Okay, the last one is there any code for vaccine that has been wasted? There's a couple different ways we can handle this. And one, I think we mentioned why you should always be paid above for a product to kind of help with some of that wastage. But two options you also have. One, a lot of practices are starting to put in place policies that, of course, always vet through your lawyers and make sure that it's not in direct violation of any contracts. But that when a parent signs off and says, yes, I want X, Y, and Z vaccines today, if for some reason the vaccines cannot be given by no fault of the practice, then you should be allowed to charge the family for that if it becomes a wasted vaccine. The other option is to bill the payer. So what you would do is, obviously you wouldn't bill an administration code, but you would bill the product code, and there's a modifier JW, J as in Jack, W as in water, that can be added to the product code to tell the payer it was a wasted or discarded product. Now, whether or not that will be successful, I can't say. I don't know if that's ever been successful, but it's an option. That is something you can do. But the other option is to have the parents, when they sign off on the vaccines to get them, is to also sign a financial waiver saying that they understand that if they waste the product, they could be charged for it. And I think that's it. All right, I think that was the last question.
All right. Thank you again for joining us on today's webinar. Please join us on our next webinar on July 28th at 12 p.m. where we will have Dr. Paul Lee from Winthrop University Hospital discussing meningococcal disease and its prevention. Once again, thank you to everyone for joining us on today's webinar, and I hope that you all have a great afternoon and a great weekend.
Thank you.